So we will start with a land acknowledgement today, and St. Joseph Healthcare Hamilton is the host site for this week's rounds. St. Joe's sits on the traditional territories of the Mississaugas and the Haudenosaunee nations and is within the lands protected by the Dish with One Spoon Wampum Agreement. This is a treaty between the Anishinaabe, Mississaugas, and Haudenosaunee that bound them to share the territory and to protect the land. Subsequent Indigenous nations and peoples, Europeans, and all newcomers have been invited into this treaty in the spirit of peace, friendship, and respect. And this is particularly noteworthy during today's rounds. We're coming to the close of National Indigenous History Month. And just this past Saturday, June 21st, was National Indigenous Peoples Day. So this is a day where we take time to recognize and celebrate the traditions, cultures, and contributions of First Nations, Inuit, and Métis people. And it just so happens to take place on the day of the summer solstice, the longest day of the year. So we will move then on to our title slide for today. And it is my great pleasure to welcome back Dr. Sandra Ofori from Cardiology and Perioperative Medicine, who will be speaking with us about perioperative smoking cessation, what is new. We also have today co-hosting with me Dr. David Conan, who just a couple of months ago had taken over the reins as the head of service for cardiology at St. Joe's. So welcome, Dr. Ofori. Welcome, Dr. Conan. I will hand things over to Dr. Conan to tell us more about our speaker today.
Thanks, Madeline. Thanks for having us. Thanks for having cardiology doing these rounds today. I'm introducing Sandra Ofori, who is originally from Nigeria, where she started her education, and then she moved to London for a Master of Science in Preventive Cardiology, and then fortunately came to McMaster to do a perioperative fellowship. And in a very short period of time, she has become a very important person in our perioperative medicine program from a clinical perspective and from a research perspective. She's also doing some cardiology work at St. Joe's and the Juravinsky Hospital. She is very active in research, as already said. She has received multiple grants already. She has received career awards. Her interests are around smoking cessation. So everybody is smoking in the hospital will have to deal with her. And so that's a very good thing. And then she's also interested in automatic monitoring and remote control of patients who left the hospital. I'm not sure that's going to be part of the discussion today, but that's another very important aspect of her work. She has published many papers already, and I'm 100% convinced there will be many more coming. And we're glad, Sandra, having you today talking to us about smoking cessation in the perioperative period. What is new? Thank you.
Thank you so much, David, for that very kind introduction. And thank you, Madeline, for inviting me to share at Rounds today. It's my absolute honor and privilege to be here. So thank you very much. So we'll just jump right into it in the interest of time. And I don't have any relevant conflicts to this, except for the fact that some of the research here is funded and supported by grants from HASO and PHRI, as well as OCR, and then none other non-relevant conflicts. So my goal today really is to look at how do I turn this slides? Oops. Okay. You pardon my, right. My goal today, can you see my slides very well?
They look perfect.
Yes.
Okay, good, perfect. So my goal today is to look at how smoking affects surgical outcomes, and then talk about the latest evidence about smoking cessation interventions, especially in the periop setting, and then focus on how we can integrate cessation support into perioperative care. This is a typical patient that we see in clinic before surgery. So 70-year-old lady, you're seeing in the pre-assessment clinic. She's booked for vulvar cancer surgery in a week's time. As part of her medical history, she has a significant smoking history, the 40 pack years of smoking. And you start to counsel her on smoking cessation, but then she tells you, look, doc, I've been smoking for decades. My surgery is next week. What difference will quitting now even make? And I've tried everything in the past, nothing works. My brother quit with vapes. Should I try that? What about these nicotine pouches I see on TV? I really don't want any more medications. You know, those types of patients we're seeing more and more often in clinic, and I hope that by the end of this presentation, we'll have more of an idea of how to deal with patients like this. This quote from the 2008 Treating Tobacco Use and Dependence Guidelines really captures the paradox of tobacco use. It's deadly, it's common, and it's treatable, but yet we fail to consistently address it in clinical care, which is something that really defies a lot of logic. We all know that smoking still remains the leading preventable cause of death, of premature death. It shaves off a decade of life from individuals. It accounts for a huge burden of cardiovascular death. 1 in every 4 cardiovascular deaths are related to tobacco use. And importantly, 1 in every 2 persons who smoke will die from a tobacco-related illness. So I don't need to tell this group about how bad cigarette smoking is, or tobacco use in general is. When we talk about tobacco use, we're most times referring to traditional combustible cigarettes, which we're all very familiar with. And over the last many decades, we've seen a slow but steady decline in the prevalence of tobacco use. As at 2020 in Canada, there was a 10.3% prevalence of cigarette smoking amongst people aged 15 years and over. In terms of total tobacco use, this was around 11.9 or so percent. But there's a slow decline. However, it's not declining fast enough. The government of Canada has a goal to reduce tobacco use to less than 5% prevalence by 2035. That's just 10 years from now. If all things remain equal and we keep declining at this rate, we'll not get there by 2035. So obviously more needs to be done in terms of reducing population prevalence of tobacco use. Apart from cigarette smoking, which is the predominant form of tobacco use, there's still other forms of tobacco use that are relevant, especially in the perioperative period, because these other sources are also related to increased post-operative complications. So combustible tobacco, which include things like pipes, cigars, hookah, BDs, there are things that we need to ask patients about because they also need to get off them in terms of post-operative complications. Then heated tobacco products, which look like e-cigarettes, but literally instead of combusting the tobacco leaf, it heats up the tobacco leaf to release a vapor. It's different from e-cigarettes, which we'll come to later. And then there's also a range of smokeless tobacco products. By and large, while these forms of tobacco use are also bad, the overall prevalence is very low, typically in the range of 1 to 2% in any population. And that's why, it's not as commonly dealt with as with traditional combustible cigarettes. But it's good for physicians in general to be aware of these forms so that when you see people who don't smoke, you make sure you're asking about other tobacco use as well. When it comes to surgery, we know that the global burden of surgery is increasing. Right now, sitting around 300 million adults having surgery every year. And surgical populations are disproportionately have a disproportionately higher rate of smoking. So depending on the study you look at, the prevalence of smoking, current smoking, that's usually defined quite variably across studies, but typically will include at least a month of smoking in the month before your surgery, can go anywhere between 13 to 30%. And these are even higher in cardiovascular and thoracic surgeries. And by and large, they're higher than what you'll see in the average national prevalence rates. Many patients who are undergoing surgery right now, with the increasing age and multimorbidity of the surgical population, we're seeing that many of these patients already have either cardiovascular disease or risk factors for cardiovascular disease, making the time around surgery a really good opportunity to intervene on a modifiable risk factor that we know is beneficial to prevent future CVD. So that's also another important point. The smoking on its own dramatically increases the risk of postoperative complications across systems, so cardiovascular, infectious, pulmonary, wound infections, 3 to 6-fold. And then people who smoke in the year after their surgery, like people who are smokers, in the year after their surgery, have a higher rate of complications requiring rehospitalizations, ER visits, and therefore they tend to accumulate more healthcare cost utilization in the year after surgery. And this has been shown in many multiple studies. Study after study have consistently shown that smoking increases postoperative complications across systems. So I don't think anybody doubts that smoking around the time of surgery or a smoker having surgery is at increased risk of post-op complications compared to somebody who doesn't smoke. So yeah, we know the harms of smoking, but we also know that there are benefits to smoking cessation in patients undergoing surgery. And the randomized controlled trials that have shown this, a 2014 Cochrane review summarized this evidence. And what they demonstrated was with intensive interventions, so these are typically multi-session face-to-face counseling, behavioral counseling for smoking cessation combined with nicotine replacement therapy, they found big significant reductions in complications when patients were able to adhere to the interventions and quit smoking anywhere from 4 to 8 weeks before surgery. So that period of abstinence before surgery significantly reduced the risks of composite post-op complications and especially reduced the risk of post-operative wound complications by about 69%. These are results that you see that I don't know that you'll see with medications or other interventions. Just by smoking cessation, you can significantly impact postoperative complications and wound healing. Now, the issue that remains is we are still uncertain about the benefits of short-term abstinence before surgery. As we know, many of us who are involved in perioperative work, we tend to see patients just shortly before their surgery. In most places, median time to seeing patients, we see patients usually within the 10 days of their surgery. So that you agree with me, that's not enough time to actually institute any smoking cessation intervention with enough time for the patient to stop smoking for you to see those post-operative complication benefits. But that's the reality of perioperative care. Patients that we are seeing in clinic just too close to surgery to make a big difference. But important to know that even though we don't know we're not certain how many weeks or days before surgery people have to stop smoking for us to see a big difference in post-op complications. We know that if they're able to stop smoking before surgery, they're able to sustain that, and that increases the odds of long-term abstinence. And if we can get people to stop smoking, we significantly prolong their survival, we significantly reduce their risk of future CVD and future death. So we know that there's no evidence of harms from quitting close to the time of surgery. So that's why even if we're seeing them a day before surgery, on the day of surgery, instituting measures that will help them quit will benefit their long-term health. Moreover, from a large observational study showed that patients who were smoking on the day of surgery almost doubles their risk for post-operative surgical site infections. So if for nothing else, getting patients to stop smoking as close to time of surgery as possible whenever you see them will benefit them, will not harm them, and will help them stay abstinent for longer with benefits for long-term health. So if we go back to our objectives, I think we know without a doubt that smoking does negatively impact surgical outcomes, and we can now try to summarize the evidence for effective interventions in the perioperative period. Now, there are interventions that are effective. Many trials from non-surgical settings have shown time and again that the combination of behavioral interventions and smoking cessation medications, of which there are only 3 approved by the FDA and around the world, including varenicline, nicotine replacement therapies, which are referred to as NRT, and bupropion, which is an antidepressant. Any of these medications combined with behavioral interventions are effective for smoking cessation, and these are the approved treatments. They have certain uniqueness about them and how they're given, which we can get to at the end of the talk if we have time. But suffice to say that these 3 are available. They're approved. Nicotine replacement therapies come in various forms: the long-acting transdermal patches, as well as short-acting formulations, the lozenges, the gums, spray, and inhaler. And it's recommended that the NRTs are given in combination, so a long-acting patch in combination with any of the short-acting formulations. And in patients who are heavily nicotine dependent, you can even combine NRT with varenicline. Our guidelines recommend this approach. Almost every perioperative guideline recommends this approach, and the wording typically will say all smokers should be offered pharmacotherapy with behavioral therapy before surgery at least 4 weeks in advance. But again, as I said before, many times in reality, we don't see patients 4 weeks in advance of their surgery. We're seeing patients very close to the time of surgery, and because there's no real guidance for what to do with these patients, there's a lot of variability in how patients are treated when they're seen close to the time of surgery. And I'll show you that there is evidence for this, again, mostly from non-surgical trials, but we have some surgical trials that have shown that pharmacotherapy, especially with varenicline, the evidence for NRT in the surgical setting is very uncertain because it's small trials with non-significant results. But varenicline, there's 2 randomized controlled trials conducted here in Canada that have shown that the use of varenicline started at least 1 week before surgery did increase long-term abstinence up until 12 months. And when varenicline is combined with behavioral counseling, either through quitline referral or in-person counseling, it's the odds of staying abstinent at 12 months is 60% higher than if you did not give the patients varenicline with this intervention. So we know, at least from this trial, 2 trials with less than 600 patients, that varenicline is effective in the perioperative setting and importantly did not cause harm. Again, with behavioral therapies, as I've said before, if patients have intensive interventions started at least 4 to 8 weeks before surgery, we have evidence that this helps them. It increases the odds of being abstinent at the time of surgery by about 10-fold and up to 12 months by about 3-fold. So these are really significant gains. But again, small trials with very few patients. In trials where the interventions are started close to the time of surgery, we see impact in number of patients being abstinent by the time of surgery, with like a 30% relative increase in the number of patients who are abstinent by the time of surgery compared to people who did not get any interventions whatsoever. However, this usually has not translated to long-term abstinence. But by and large, we do have some good evidence that this approach is helpful in the perioperative setting. The problem, though, is that it is inconsistently applied. And we have data from our large VISION study. So for those who are not very familiar, VISION was a large prospective multi-center cohort study that was led out of Hamilton by Dr. PJ Devereux. There were 28 centers in 14 countries, and it involved adults who were undergoing major non-cardiac surgery. So we used the opportunity of having that database to look at smoking in that population. And it was interesting to find that across a representative sample of patients undergoing various forms of non-cardiac surgery, prevalence rate of smoking, which we define as smoking in the month before your surgery, was almost 14%. And importantly, 2/3 of them were smoking up until the day of surgery. 60% resumed smoking postoperatively in a median time of 5 days post-surgery, right? And very few of them were on medications. Only about 7% were on any smoking cessation medication before surgery up until discharge. Of that, less than 1% were on varenicline. And this highlights a major missed opportunity, especially since in that cohort, we also found that people who were smoking at baseline were at a higher risk of cardiovascular events at 1 year. So we can see the situation where patients are coming to surgery, they're smoking, they go ahead with surgery, they resume smoking after surgery, and they don't really get intervention as we should. If you think about this, I'm sure none of us will feel comfortable sending a patient who has uncontrolled hypertension to have surgery. But the same is not really translated when it comes to smoking. And there are many reasons for this, and we'll get into that a little bit. What I wanted to point out with this slide is that in that VISION cohorts, we can see that the prevalence of current smoking kind of varied across the types of surgeries, with the highest prevalence in patients undergoing vascular surgery. 30.9% of them were current smokers, and then thoracic surgery, 16.1% of them were current smokers. And the rate of prescription of pharmacotherapy was very low across all of them. But something that's really striking here is even amongst the subpopulation of patients who have active cancer at the time of their surgery, only 8.4% of them were receiving any treatments for smoking. Again, highlighting this missed opportunity that we have. This is not just here, like there's other studies that have shown this. This was a large observational study in the US, and they looked at patients in the outpatient clinic undergoing surgery. So this is, you'll see more, there was time to intervene because they were seen in clinic. And even in that population of patients, almost 65,000, again, around 14.7% of them were currently smoking, and only 12.7% were provided medication, with some variation across types of surgery. Highest in cardiothoracic surgery with 22% and lowest in general surgery. So again, we can see that across surgical populations, there's really underutilization of the existing treatments that we have. And it's not very clear why this is. There's in the early 2000s, there was like talk about the concept of the hardened or hardening smokers, where the thought was patients, with all that we know about smoking, all the harms, all the policies, those who can quit have already quit. So the ones we're seeing are the ones who are unable to quit or who have just a harder time quitting. So maybe that's kind of why. And we see that many smokers that we see in clinical practice tend to be slightly different from what you see from people that you'll see like in communities, because these are usually patients who've had like longer duration of smoking, heavier dependence, and many times are having surgery for diseases that are caused by smoking. So these are people who have had previous unsuccessful quit attempts. So there might be a difference in the population of patients that we're seeing who are having surgery compared to patients who are like free living healthy in the community. So that's something to bear in mind when you see patients in the surgical setting. We looked into this, trying to understand what the barriers and facilitators for smoking cessation in the perioperative setting is. And we conducted a scoping review, included 31 studies that were published after the year 2000, most of them in high-income countries. And interestingly, we found that the most frequently reported barriers were clinicians' lack of knowledge and time, concerns about patients' readiness to quit smoking around the time of surgery. And in about a quarter of the studies we found, they showed that there was a belief that cessation wasn't the surgeon's responsibility, which is understandable. But on the other hand, we found that where quitting advice was integrated into routine clinical care and patients leveraging the surgical moment as a motivating factor, and where there was training on smoking cessation interventions, these were helpful facilitators for smoking cessation. So it's important for us to know that in the periop setting, as we know, there's little time for prolonged or intensive counseling. We are not necessarily trained in that anyway, and there's uncertainty about the effect of starting the medication so close to the time of surgery. So these things might account for why we found repeatedly that there's very low rates of use of smoking cessation therapies in the surgical period. So what about newer treatments? So Cessation, for instance, we'll get into that. Vaping, e-cigarettes, other nicotine products, where do we stand with this and what does this mean for the practicing clinician? With Cessation, as some of you may know, or hopefully now more people know that as it's getting more known, is a low-cost plant-derived smoking cessation aid. It acts on the same nicotine acetylcholine receptors as varenicline, so it's a partial agonist and antagonist. And what that does is that it blocks the rewarding effect of nicotine, and it still has some dopamine release. So the person who's on Cessation doesn't have as much craving, and they have fewer withdrawal symptoms as if compared to if they just stop by themselves. It's actually is the molecular basis from which varenicline, that we all know is the most effective treatment available, was made from. And Canada is sort of like one of the first Western countries to approve Cessation for use, but it's approved in Canada as a natural health product. So I'm not sure if that's the reason why it's not as well known amongst practitioners as varenicline and the other medications. So it's actually an approved smoking cessation medication. Importantly, as a natural health product, it might appeal to patients who don't want medication, quote and unquote, and it's the cheapest of all the available pharmacotherapies compared to NRT, varenicline, or even Zyban. So there's lots of evidence for its use. Trials have been published in high-impact journals comparing cytosine to placebo, to NRT, and even to varenicline. And we summarized this evidence in a systematic review that included 14 trials with almost 10,000 patients. Our primary outcome was the most rigorous definition of smoking cessation, which is biochemically verified continuous abstinence at 6 months, i.e. from quit date to follow-up at 6 months, no smoking, and it was biochemically verified. And what we found in a nutshell was that cytosine was superior to placebo, with a relative risk of 2.25 with moderate cytosine evidence. It was superior to NRT. Relative risk of abstinence was 1.39, but low quality evidence for few studies and imprecision. It was the relative risk compared to varenicline was 1.13, but this was not statistically significant. But what was important in this review was, compared to varenicline, which we take as the gold standard, cytosine was 33% less likely to cause adverse effects. Most of the adverse effects related to varenicline and cytosine, they have the same sort of mechanism of action. It's mostly GI related, like nausea, and then in a few cases, abnormal dreams. So cytosine seems to be similar in efficacy to varenicline, but with fewer side effects, and it's cheaper medication, so it may be more acceptable in the perioperative setting. What we found in that review was that there was no trial that was done at all in any surgical setting. So we set out to sort of test this out in our trial. The reason why we did this is, one can say, oh, it's already approved, or we already know from non-surgical trials that it's effective. But we know that surgical populations might be different in some way from non-surgical populations. Plus, we don't know what the tolerance will be. Just having surgery may not be able to tolerate a medication that causes nausea and things like that. So, we know from other large periop studies that drugs that have been shown to be effective in non-surgical settings sometimes have a different finding in surgical patients. And an example would be aspirin, for instance. So aspirin, we know that it's a good secondary prevention medication for people who have cardiovascular disease. But in the POISE trial, where we looked at aspirin to reduce cardiovascular events, there was an excess risk of bleeding that kind of negated the benefits of aspirin in that population. So actually having a definitive trial in the surgical setting will, I think, provide evidence that would encourage, or at least help physicians to make a decision whether or not to use this medication. So anyway, we went ahead to design this trial. It's called the PREVENT trial. We designed it as a 2x2 factorial pilot trial, testing cytosine as pharmacotherapy and personalized video messages for behavioral therapy amongst daily smokers who are waiting for their surgery within 28 days across 3 Ontario hospitals. The goal of the pilot was to assess feasibility for a larger multi-center trial. The behavioral component was essentially, think about it this way. We know that we don't have time in the periop setting to do the intensive interventions. So all the things that you want to tell the patient about smoking, the benefits, the harms, and all of these things, and how to deal with cravings, how to deal with withdrawal, how to get through the day without smoking. We developed a batch of 16 videos where we address each of these issues, and patients who are enrolled in the trial arm will get text messages on their mobile devices and with an embedded link to the video within the text messages, so they can click on the link, watch the video several times, even download it and save it. And we had a whole library of messages that patients will get 2 a week for 8 weeks. I won't go into playing the video, but it's just to give you an idea. The messages were tailored to the timing of surgery. So there were messages that were for pre-op setting, for the just immediately post-surgery, and long-term health benefits of smoking cessation. Patients could personalize the video, so they could, when they enroll in the program, they could choose their avatars. They could choose to have they could customize the skin tone, the gender, just things to make the videos more relatable. So we'll move on. And these were the key eligibility criteria. We enrolled adults who were undergoing surgery within 28 days, who were smoking daily, were not on any cessation medication, and had a mobile device with an internet plan. We excluded patients essentially who were pregnant or breastfeeding or had acute uncontrolled medical illnesses at the time of randomization. Our primary outcomes were really focused on feasibility of recruitment and follow-up. So we wanted to make sure we could recruit at least 2 patients per center per month across the sites, as well as follow-up on more than 90% of them. We also had some secondary outcomes exploring adherence, feasibility of biochemically verifying abstinence, post-operative complications, and things like that. But the key point of the pilot was assess feasibility of recruitment and follow-up. We started the trial. We plan to enroll 100 patients in the pilot phase. We screened 616 patients to find 87 eligible. I want to draw your attention to the arrow, the red arrow, showing that of the 43 patients who were eligible but not randomized, 22 were not randomized because of physician refusal. And this just highlights to us the point that we need to do more advocacy within our physician group, surgeons, to understand why they'll be reluctant to enroll their patients in the smoking cessation trial close to the time of surgery. We eventually randomized 44 patients, 23 in the Cessation arm and 21 in the placebo arm. And then for the behavioral arm, 23 in the standard of care, which is no messages, and 21 in the messaging arm. Unfortunately, we had to prematurely terminate recruitment due to unforeseen circumstances with the video messaging arm, and we stopped the trial in January. As you can see from this graph, as with many trials, it starts very slow, and we started to ramp up. And just as we're really ramping up on recruitment, we encountered the issues that we had, and then we had to stop the trial. Anyway, having said that, we still managed to meet our recruitment rate. So we were recruiting at a rate of 6.5 per center per month on average. We completed follow-up on all but 1 patient, so 97.7%. So we did technically meet our feasibility outcomes, even though we didn't finish the trial. And in terms of adherence, we hoped that most patients, I think we were planning for 80%. We didn't put a proportion because it wasn't the main feasibility outcome, but obviously in many smoking trials, we aim to have at least 80% adherence rate, but we found that we had only about 57.6% adherence rate. And the 1 patient who reported continuous abstinence was not able to come into clinic for biochemical verification. So there were some issues there as well. I'll just run through just a few key highlights about this population. So as we can see, bearing in mind it's very small, so there might be some imbalance between the groups just because of how small the numbers are. But we can see that majority of the patients have heavy smoking histories with pack hair history of 34 years in the Cessation arm and 33.4 in the placebo arms. Many of them had prior quit attempts. Very few had successful quit attempts, and a good proportion of them were living with a smoker. So these are patients who, despite their relatively young age, had very heavy smoking histories and have close proximity to other people close to them who smoke. And that makes it more difficult to stop smoking. When we look at the exploratory outcomes, we can see sort of a numerically higher proportion of patients in the Cessation arm reporting abstinence at all the follow-up time points compared to the placebo arm. But again, these are very small numbers and it's just really exploratory. Those in the Cessation arm had a longer time to return to smoking versus those in the placebo arm. And when we looked at the clinical outcomes, we also see a numerically higher number of patients in the Cessation arm reporting, post-operative events. Although none of these were adjudged to be due to the medication of the study medication, these are underpowered analysis, but the direction of effect is, warrants some careful consideration of what's going on there. But none of them there was no serious adverse effect that was reported in the trial. So with our pilot trial, we kind of had to terminate early due to an external cause. We managed to show feasibility of recruitment and follow-up, and we saw that there was suboptimal adherence, but there were similar rates of discontinuation in both arms, so whether on placebo or not. And again, as I mentioned, there were some more clinical events in Cessation arm, but no serious adverse events were reported. So what we've done is that we're building on the lessons from the pilot. We've adapted the design to better capture a broader population of people who are smoking. So now we're going to include people who vape, e-cigarettes, or use other products as long as they're also smoking. And because we're focusing on the perioperative period as the window, we're removing the time limitation. So whenever we see them before surgery, they're eligible for the trial. And just so that we don't exclude patients because their surgery is not yet booked or their surgery is more than a month in advance. So we applied for full for funding for the full trial, and we're keeping our fingers crossed that we get it so that we can really study this this intervention. Now, I'll just spend a few minutes talking about other nicotine products. So more and more, we're seeing patients who are vaping coming to clinic or coming for surgery. It's interesting because if we look from this graph, we can see that the prevalence has really taken off, especially in young people. So if you look, you can see like back in 2013, about 20% of youth aged 15 to 19 reported any e-cigarette use, and this more than doubled by 2019 in the short time of 6 years. And this is increasing even amongst older age groups. So we're having more patients who are coming and are reporting trying to stop smoking with vaping or just vaping. So it's important for physicians to know more about this. We did a survey of periop physicians and cardiologists. I haven't analyzed the results, but I was looking at it last night. And as expected, majority of the respondents, have no good knowledge of e-cigarettes, don't prescribe it, don't know how to recommend or advise patients about its use. E-cigarettes are relatively new. They were introduced in 2003. They are essentially battery-operated devices that deliver nicotine efficiently, sometimes at rates even higher than cigarettes. The heat up the nicotine-containing fluid and release the vapor, but the aerosol, or not the vapor, the aerosol also contains harmful metals and volatile compounds. And despite the fact that they have lower carbon monoxide levels, lower toxicants than compared to cigarettes, the rapid uptake by youth that is mostly driven by tobacco industry marketing really raises concerns about addiction and long-term use and long-term health risks. Importantly, there's no approved dose. Physicians are still very ambivalent about their use, and that's understandable because they are all produced and marketed by tobacco industry. More importantly, there's a huge variation in the devices, in the liquids, from refillable tanks to disposable closed systems. It's very hard to standardize the exposure, very hard to assess long-term risk because of how relatively new they are. And unlike cigarettes, we don't know how to quantify the use. So how much somebody vapes and what they're inhaling can vary dramatically depending on what they're buying. So again, that makes it difficult to standardize advice or anything concerning them. But there's more studies coming up on e-cigarettes. Again, many studies published in high-impact journals looking at the effect of e-cigarettes for smoking cessation. And the Cochrane Group did a summary of this in the meta-analysis of 90 studies, of which about 49 were RCTs involving almost 30,000 adult smokers. And essentially what they showed was that nicotine-containing e-cigarettes improved quit rates compared to NRT, compared to non-nicotine e-cigarettes, and compared to behavioral or no support, with pretty high satisfaction for the NRT comparison and moderate for the non-nicotine EC comparison. And there was really no difference in adverse event rates between the e-cigarettes and NRT. But again, they did not use what I would term a standard comparator in these trials. So many of these trials were using either short-acting or single NRT versus the recommended combination NRT. So it's hard to gauge to see why electronic cigarettes seem to be more efficient. And the data were from non-randomized studies were also consistent, so reinforcing the evidence that perhaps they may be useful more than even NRT for smoking cessation. But we still need to exercise caution. This randomized control trial really was conducted amongst patients. They looked at uptake of e-cigarettes. So they offered patients e-cigarette or no e-cigarette to see how many will take up e-cigarettes. And what they found was, yes, the patients that took up the e-cigarettes reduced their smoking. There was about an 8% quit rate, but there was 34% absolute increase in number of dual users. So whatever benefits you're getting from quitting smoking at a population level is likely overtaken by dual use of vaping e-cigarettes and smoking traditional cigarettes. So that is bad. The other thing is there's large studies showing associations between e-cigarettes and heart failure. So this large NIH observational study showed that amongst people who were daily e-cigarette users, the incidence of new HFrEF was higher compared to people who were never users. New HFpEF was higher compared to people who were not users. And even after excluding traditional cigarette use, the association was still significant. Similar large survey looking at the incidence of myocardial infarction with daily e-cigarette use, again showing increase in the risk of incident MI amongst patients who are daily users. Now, one of the problems with these analyses is that it's difficult to tease out the effect of historical tobacco use on the incidence of heart failure and MI, even though they try to do a lot of matching and adjusting for confounding factors. But I think this is all pointing to the fact that we don't know what the long-term risks are. There's signal of harm with e-cigarette use, even though they may be effective for smoking cessation. Importantly, again, there's no perioperative trials of its efficacy or harms in this setting. What about other nicotine products? So more and more we have nicotine pouches, which are essentially small bags filled with nicotine that people can put under their lip and slowly absorb nicotine from that. In 2023, Health Canada approved Zionic patches, nicotine pouches for sale in Canada. Each tiny pouch contains 4 milligrams and you can use up to 15 a day. Now that is 60 milligrams of nicotine a day. To give you context, a stick of cigarettes, you can probably get like 1 milligram of nicotine from that. So 1 pouch is equivalent to smoking 4 cigarettes. And this was approved by Health Canada. Interestingly, they are all produced by tobacco industry companies. So Zionic, for instance, is produced by Imperial Tobacco that has a simple mandate to reduce public health harm associated with their traditional cigarettes. And I think, if you're really interested in doing that, you just stop producing cigarettes, but what do I know? But then they market it as, very flashy, pop it, tuck it, and it tingles, in various flavors. I don't think that's targeted at my 70-year-old lady who's undergoing surgery for vulvar cancer. I think it's more targeted towards youth, and there was an understandable outcry. And eventually last year in August, the government kind of backtracked and they banned the sale of other flavors except for mint, and it can only be sold behind the counter in pharmacies to try to restrict access to youth. But again, these products are unregulated, produced by the tobacco industry, and there's no evidence that they are better than traditional NRT that we know and are already approved treatments. So having said all of this, we need to discuss how can we incorporate smoking cessation in perioperative care. So there's opportunities, right? The opportunity is that surgery is a teachable moment. Patients are focused on their health. They're going to have surgery. They're going to be in hospital where they can't smoke. So there's an opportunity to leverage upon that to kind of turn that temporary abstinence to more of a permanent or long-term abstinence. But then the unique challenges of seeing patients who are typically highly nicotine dependent, who have understandable concerns about starting a new medication very close to surgery, which we saw in our pilot trial, time pressures in the clinic, lack of expertise of the practitioners, uncertainty that still remains around the effects of quitting very close to time of surgery. All of these things kind of play together to make it a bit more challenging than we would like. But we think that is worth a systematic approach that is framed as an opt-out 3A approach. I'll tell you what 3A is in a moment. Can make this cessation support routine, and it can be applied at every time point before surgery in the pre-op clinics, in hospital, and then in the post-op clinics, and even in our virtual perioperative care program, which we're kind of very lucky to have in Hamilton, because that allows for a continuity of care across the patient surgical journey. So the 3A approach, so what this is the traditional 5A approach to smoking cessation, which is your ask, advise, assess willingness to quit smoking, assist, and arrange follow-up. Now, what used to happen is basically what this means, that's the 5A. So you ask patients about their smoking history, you advise them on smoking cessation, but we used to get stuck on the assess willingness, because this makes you ask the patient, how willing are you to quit? So once they say they're not willing, then it ends there. There's nothing you're doing. So the 3A model is kind of like a diversion from there, where you ask, advise, and act. And this model was demonstrated, like it has been adopted by the Cancer Care Ontario, and it has been demonstrated in a regional cancer center here in Ontario to be an effective strategy to at least increase the amount of accepted referrals to smoking cessation by patients. So it's a model that has been adopted by other organizations, and we can see that we can adapt it to our perioperative care setting. So what we're doing in the meantime, while we're trying to set up this program, is with the 3 A's approach, we're asking all patients about the tobacco use, including other forms of tobacco and other nicotine products, advising them to quit because we know that even brief advice increases the odds of quitting. And then the ACT is using the opt-out approach. You're going to be prescribing pharmacotherapy for patients and referring them on to community supports. So the same way that we try to, we see patients with dyslipidemia, we give them statins, we see patients with hypertension, we give them amlodipine, we see patients who are smoking, and our scripts include NRT or varenicline or bupropion as appropriate, but also referring them on. And we have this booklets that we got from the Public Health Hamilton office, and we can usually what we use is that the patient can call any of these numbers and be set up with free NRT from the government for 12 weeks and can be extended. We can enroll them on Stop on the Net, which is an online program. They get support from there too, as well as free NRT. Or just enroll them, call this number, and they get enrolled in the Ottawa model for smoking cessation, where they get both behavioral counseling support as well as NRT delivered to their homes. So this is what we're doing while we're still trying to work on implementing the STOP program in our hospital system as well. So on a broader level, the goal will be to implement a systematic approach in all our healthcare settings, identify all smokers, clearly advise with consistent messaging about quitting smoking, prescribing any of the approved medications in the combination that they need, personalizing it according to the patient, arranging follow-up or referring on to community supports, and other things that we can consider are e-cigarettes for smokers who are unable to quit with other medications or unwilling to try with other medications. And then at a systematic level, we also have to advocate for public policies, like free access to smoking cessation medication, because it's still one of the things that's a sticking point. The cost of the medications far, far outweighs the price of cigarettes. So it's very difficult to convince patients to spend that money for something that will benefit their long-term health. And just to end by saying that we worked on a smoking cessation clinical practice update. If you scan this QR code, it will take you to the paper. We try to really break it down for the practicing clinician, and for perioperative and other healthcare settings, it's relevant to any of those settings. So this is an interesting, simple to read clinical practice update that we published in the CJC this year. So in conclusion, we know without saying that smoking worsens clinical outcomes. Surgery is a teachable moment that we need to leverage upon. Treatment uptake still remains low. Cytosine has some distinct advantages that we think might make it more acceptable to patients and may increase uptake, but we still need a definitive trial to inform its use. Imperatively, we should all strive to ask every patient if they smoke or use any other tobacco products or nicotine products. And for those who are using tobacco products, offer all of them treatment using the opt-out approach. And even if we're seeing them very close to time of surgery, bearing in mind that long-term abstinence is what really matters for their long-term health, that should make you not hesitate to institute smoking cessation interventions. And as at yet, we still don't have enough evidence for the emerging nicotine products to advise or strongly recommend for their use, but they may be used as a harm reduction strategy for patients who are unwilling or unable to quit with other approved medications. So I would like to end by really thanking our perioperative care and research group at PHRI, led by Dr. Devereux, as well as all our study sites, investigators, our research team, the awards that we got from PHRI, HASO, and industry to support our trial, as well as my career awards that are supporting my research time. So thank you very much. And I will stop sharing my screen so that we can see the audience and take questions, if that's okay.
Thanks so much, Sandra. Very important topic, very good overview of a very challenging issue. Please set your questions into the chat or raise your hand so that we can hear you. While people are doing this, I ask you my usual question. So how teachable is the perioperative period? How do you think that you can approach a patient who has a major intervention on their body, while it's health related for sure, but isn't there a risk that you can also overwhelm some patients that they're not ready to quit, especially in the setting of pain and other issues with their body?
Yeah, that's an excellent question, and it's a question that comes up, time and again. And I agree with you. We know, like previous studies have shown that surgery is a teachable moment that we can capitalize upon. But I agree with you that for everybody, it will not be a teachable moment for everybody for everything. However, as part of Prevent, we did this qualitative sub-study, and we kind of tried to ask patients these questions. And it was interesting, the responses we got. So sometimes it's about framing, it's how we frame the conversation. It's up until now, I think we still sort of think about smoking as a habit versus an addiction. I'm sure none of us on this call will see a patient with an active raging addiction or uncontrolled medical condition and not want to bother the patient with overwhelming them. So I think it's about the approach and explaining, or making them understand that it's part of their surgical care, it's part of what will help them through surgery, it's part of what will help deal with post-op pain. And the key thing is, if you're trying to get somebody off cigarettes, you have to make sure they're getting nicotine. So there's a lot of under prescription of NRT around the time of surgery that doesn't help. So the patient's going to nicotine withdrawal, we will exacerbate their pain, their anxiety, the nausea, and all these things. So reassuring them that getting off smoking, even close to time of surgery, will help your surgical recovery and will try to help you, navigate that whole period with replacing your nicotine. There's a lot of misconception about patients around NRT, especially feeling like I'll get addicted to nicotine, or I don't want the patch, or this or that. Like there's many things that we can deal with around that time. For patients who have true patch allergy, which is quite rare, there are other things that we can do. But many of the concerns around irritation can be dealt with local anesthetic creams and things. So there's a lot of opportunity to educate patients as well as ourselves to help patients through this time. But there will always be a few patients for whom it's a non-negotiable. They're not going to give up their cigarettes. This is the only thing they're holding on to, is their crutch. And I mean, I think we have to accept that we can't reach everyone, but I think a lot of patients are amenable and open to trying if we really frame it in the right way.
That's true, but it's also, the pain is so overwhelming in some people that they may just not be ready to take on another thing at that moment, even if they previously said, yeah, fine, but anyhow, I think Anne Holbrook has a question, and we have only 5 minutes left, so I want to have other people as well giving their opportunity. Anne? Anne has disappeared. At least her voice is not there.
Oh, somebody has to unmute her. Let me see.
Yeah.
Allow mic. What about now? Okay.
That's it.
Okay.
There we go.
No, she's still muted. Sorry for that. I don't know how this disable mic. No, that's the one. So now can you unmute yourself now?
Is that better?
Yes.
Yeah, there we go. Sorry about that. So just a quick question, Sandra, as I wrote in the Q&A there, so natural health products in Canada are very poorly regulated. So no quality control, often contaminated. So I just wondered how you ensured that your version of cytosine, and then even then it's going to be a problem out in the real world, getting a reliable product. I just wondered how you ensured your quality control.
Yes, thank you, Anne, for that question. And I also want to thank you because you raised this issue with us, like I think in 2022, that prompted us to really look into this. And when we applied for the trial, we applied to Health Canada, and we had to the company that we're using is an approved company by Health Canada for providing cytosine. But then they also had to send all the documentation and samples to Health Canada for like some reapproval process. When we got that approval, we're sort of committed to using only their product because that's the one we got approval for. I can't really speak to like all the others, and which is the concern, because if we do show that this works and patients can get it over the counter, like how are we sure that this is, what is the content of this natural supplement? Yes,
exactly.
I don't know. I don't know what the process, like, I don't know if medications are natural health products. It seems to me that there's no way that it can be that can change, because like in the UK, it's not a natural health product, it's a prescription product. So I'm not sure how it came to be a natural health product in Canada, and if there's any opportunity to change that at some point in the future. I have no idea, but you raise a really good point.
Yeah, there would be, but it'd be up to the company. We can take it offline later on. Thank you.
Thank you. Thank you very much.
Thank you so much, Dr. Ofori, and thanks, Dr. Holbrook, for those questions. I think this brings us close to the end of the round. So if there aren't any other questions.
There's a question. I see a question in the Q&A from Dr. Borges.
Okay. Thank you. Do you want to read that out loud for everyone?
Yeah, she says, how do you deal with patients that insist they want to quit cold turkey? Again, that's a really good question, because across the studies, majority of the patients who quit cold turkey, and even in our prevent pilot, of the patients who had a previous quit attempt, more than half of the quit attempts that lasted more than a year were cold turkey. So there are patients who will quit cold turkey, and that's fine. But then also as long as they understand that it would be easier to quit if you have a drug that reduces the craving, a drug that reduces the pleasure you have from smoking, a drug that will, allow you get over the hump of the withdrawals, because the withdrawals kind of peak by day 2 or day 3 of no cigarettes, and then it's really bad, and then it can really calms down. And that's for people that resume smoking. 3, 4, 5 days are the time when they resume smoking. So even if they want to quit cold turkey, that's fine if they're committed to doing it, but like also making them understand that we can give you something to help the process, make it easier, and then you can come off the nicotine patches. It doesn't have to be, you don't have to use it the full 12 weeks. Or if it's very clean, you don't have to use the full thing. But yeah, that's the most common way people try to quit smoking. Again, also just to add that, pointing out that many of those quit attempts are not lasting, and they will probably have to make many quit attempts before they are fully abstinent. So just kind of preparing them so that they don't feel like, oh, I tried, I failed, and therefore no need to try. It's priming them to know that there'll be likely many quit attempts, but as long as they keep trying, that they'll eventually succeed.
Thank you so much, and that exactly reflects the comment that Dr. Holbrook has added there in the Q&A as well. So thank you so much. Such a big and important topic. I think both in your presentation and in the Q&A, you've also highlighted the very important area of policy and regulatory decision making. And I think probably another topic for another day highlights, the role of well-educated healthcare providers and researchers such as yourself in really advising on policy in that sense. I want to thank you so much for your expertise, for the passion, and the work that you do in this area, and for sharing it with us today. I want to thank Dr. Conan again for co-hosting today in his cardiology head of service role. Thanks to all the attendees. This wraps up our 2024-2025 Medical Grand Rounds academic year schedule. And I want to wish everybody a wonderful day, week, and summer ahead.